When considering about temporomandibular dysfunctions, or TMDs, many aspects must be clear within a scientific basis. First, because it leads to symptoms of pain in the face, head, and ears, it can substantially reduce quality of life. And second, it has a close relationship with dentistry, once the treatment frequently ends up in a dental chair. When talking about treating temporomandibular dysfunction, or TMDs, the first idea that comes to mind is the image of a bad temporomandibular joint. What we should take into account is that the temporomandibular joint is one of the most adaptive joints in the body. Among synovial joints, it is the most versatile, since the two joints have to work together at the same times during the mastication cycle. So, we should expect from them a bold mechanism to remodel itself. Disorders exclusive of the joints are uncommon and usually are linked to injured trauma or degenerative systemic conditions such as rheumatoid arthritis or progressive degenerations in the joints. On the other hand, articular disc displacements and deformations in the head of the jaws are variations of a normal that should only be treated when there's pain symptoms or worsening mouth opening. It is estimated that a good percentage of the population has the articular disc displaced with or without reduction and doesn't even know about it. This happens because only in a minority of people does the articular disc becomes a mechanical restraint that takes to complaints of limited mouth opening. The great capacity of the temporomandibular joint to remodel seems to be linked to an accurate histological response, with layers of indifferentiated cells much sensitive to functional and parafunctional demands. This wonderful adaptive skills allows this joint to cope with any changes in the mastication system, so it almost never malfunctions, it adapts. The great majority of the temporomandibular dysfunctions are of muscle origin primary. Sometimes it might give rise to joint derangements, but when the muscle health is achieved through a better function and coordination, the result is promptly felt by the temporomandibular joint that again adapts. So we shouldn't be so concerned about the temporomandibular joint, but rather look more strongly at the main nature of a TMD itself. Essentially, a temporomandibular dysfunction is a disease of musculoskeletal origin, so it's necessary to consider the pathophysiology of general musculoskeletal diseases. There are a number of risk factors involved in the developing of a TMD. It is a multifactorial condition, which makes the approach seemingly more general than local. Nevertheless, for many decades, we dentists have long made the mistake of ignoring this broader context, pointing a primary cause for TMD in a dental arrangement, thus underestimating the remodeling potential of the temporomandibular joint and overestimating the influence of teeth occlusion in producing such a complex dysfunction. For a TMD patient, a close examination with validated diagnosis criteria must be carried out to identify potential risk factors, and only a final evaluation should involve teeth and their occlusion. Just the opposite of what usually is done in dentistry. One of the first things dentists consider in a TMD patient is the occlusion of the teeth or poorly adapted dentures and worm restorations. However, the treatment based on conservative control of detectable risk factors takes to a very satisfactory result. The management of conditions closely related to the pathophysiology of a TMD, such as behavioral aspects, muscle overuse or overload, chronic pain along the body, or psychological factors, for example, are essential before any treatment planning. The dental arrangement as a relevant risk factors in triggering and perpetuating a TMD occurs only in a very small minority of cases. This has long been known in the field of temporomandibular dysfunction, but still, many approaches have followed old paradigms. Normally, we tend to relate any dysfunction in the mastication area to the teeth. Well, but the temporomandibular dysfunction is much greater than that. Reducing a TMD to an occlusal disorder is to reduce its real importance. We have heard of several dentistry methods for treating TMD along history. Not rare, in general clinician, A TMD is associated to a simplistic interocclusal device, or if one adapted dental prosthesis, for example, might be prone to firstly suggest occlusal rehabilitations to control pain, or if adapted surgery tends to recommend surgical measures for the temporomandibular joint. Also, as an orthodontist, I often hear about the use of orthodontic treatment to help in TMD patients. But it's important to remember that occlusal conducts are insufficient for most TMD patients, especially when used alone. The justification for any occlusal treatment can be chewing improvement, oral health maintenance, or aesthetic reasons, but very little it has to do with treating or preventing temporomandibular dysfunctions. So, to connect a TMD to an interocclusal device is not to consider its pathophysiology. But one should ask, and when does a rehabilitation in a TMD patient decrease the symptoms? Either through an interocclusal device, orthodontics, prosthesis, or surgery. Why does sometimes the patient gets better? Well, the positive result after occlusal rehabilitation is still not well known to science. It may be related to a temporary neuromotor adjustment as the intercuspular range was changed. Proprioceptors and motor neurons that control the mastication system are blind, cannot identify whether you have placed an interocclusal device or replaced all teeth. But once the motor response is adapted to the new occlusion design, the system will again be subjected to harmful elements of major risk that truly were the responsible for the symptoms. Then pain comes back after the patient has spent enormous amounts of resources on dental care. The approach, in a conservative way, can greatly improve patients' conditions, believe me, without touching a finger on teeth, respecting the features of the disease, which is intermittent and self-limiting. All that patients in pain do not need is a trial and error treatment causing more anxiety and uncertainty within unsuccessful results. All that patients in pain do need is attention and information about what's happening to better understand their limitations and what could be modified for achieving pain relief.